My name is Dr Jessica Yin. I am a consultant urologist and an associate professor at Notre Dame, and I've been invited here today to talk about genitourinary syndrome of menopause. It's a term that we now use for the old condition called vaginal atrophy. So genitourinary syndrome of menopause, or GSM as we like to call it, is a collection of symptoms essentially. And they involve symptoms that target the vagina, the vulva, but also the urinary tract, the pelvic floor. So it's across the board. And there are more sort of, esoteric symptoms that relate to things like libido and sexual function. We used to just describe vaginal atrophy as those sort of changes within the vaginal skin or epithelium or tissue. And now we realize that it's actually a broader concept. So we're sort of looking at it from all of these aspects. And I think what's really interesting about it is that there's more of a focus on it now, because I think a lot of female conditions are coming to light and there's more emphasis on female conditions, whereas previously much of medicine was taught by men, with a preponderance of male oversight. And I think now we're getting a lot more female doctors in, and we're starting to see a lot more focus on female problems. So the kind of symptoms that people are describing involve things like discomfort or dryness around and inside the vagina during intercourse. That's a classic one. It can be the loss of lubrication. It can be a sort of tightening of tissues, a feeling of burning down there. But it can also lead to things like, or cause problems along the lines of prolapse. It can cause pelvic floor dysfunction, where people might have difficulty, with their urinary control. You can also get symptoms associated with frequency and urgency of the bladder, and frequency and urgency in effect can lead to urge incontinence, struggling to get to the toilet in time and leaking on the way there. People do also report things like pelvic floor hyperactivity or tightening of the pelvic floor muscles, which then leads to problems with intercourse if you can't relax your pelvic floor muscles. And if you're always on with your pelvic floor, you sometimes have difficulty bracing when you need to. So if you cough, laugh and sneeze, you can't brace in time, you might have problems with leakage then. So it's a whole plethora of things, including things like libido, and just generally sort of the need or want to have sexual activity. So there are a lot of symptoms involved in that sort of syndrome, but it's really interesting to note that many women actually don't report it. So there was a study that was done, I think it was a women's midlife study, that showed that when you examine people who have, potentially these sorts of problems, 60% of them might actually have physical findings of GSM, but only 10% of women are actually reporting symptoms. Now, I find that really weird, because I think, okay, is it that they're not recognizing that those symptoms might be problematic? Are they downplaying their symptoms? Are they embarrassed to talk about the symptoms? Or do they just not care? If their issue is sexual dysfunction and maybe their husband's had a prostate operation and is no longer able to have intercourse, maybe they just don't care, So it's really interesting, this disconnect between the findings that we see when we examine patients and the lack of reporting. And there's, again, the Melbourne midlife women's study showed that if you're talking about perimenopausal symptoms, at perimenopause, about 4% of patients will have sort of symptoms like this, but by the first year after menopause, it rises to about 25% of women. And 3 years after menopause, you get about 50% of women reporting some or all of these symptoms, And they can be mild, where a lot of people would disregard it or just consider it to be a normal part of aging, to really debilitating symptoms where women, think, I'm going nuts. This is all, happening to me, and I'm not sure what this is. And I guess there is a fear too that some of those symptoms, particularly things like the cognitive changes, the brain fogginess and stuff that accompany a lot of menopausal symptoms, might be something more sinister. So people do back off because of the fear that maybe something down there might be associated with a vulval, vaginal, cervical cancer or bladder cancer or something like that. So there's that fear that there may be something else going on that limits people reporting things as well. So I think we've got, we're in a better world now, where, as I said, the focus has been on men's disorders and men's diseases for centuries, but now with lots more women getting into medicine, their lived experience doesn't marry up with what we've been taught in the textbook. So we're just going, well, hang on a second, that's not what I feel, So now women are actually coming into this space. I think there's a lot more focus on conditions like endometriosis, menopause, and you'll see it all over social media, you'll see it in the news. There's a lot more emphasis on that and research in that area, which is great. So I guess I would say to patients who are concerned or worried about it, especially people who read a lot of health literature and news in the social media and sort of mainstay media programs and things like that, if you have a little bit of knowledge or a few concerns, come in and see an expert. And there are many more experts now than there were beforehand, and many of those are women. Okay, so and I don't want to discount my male colleagues. There's some fantastic sensitive male colleagues who are really up with the latest findings, the urogynecologists particularly, who are good in that sort of field. But it's open now, it's more open. And I think exploring a few ideas with experts will help sort out what is social media myth and what is more realistic according to scientific research. That it's very easy, and Dr. Williams will attest to this, it's very easy to ascribe all of your symptoms to menopause. So this is a dangerous potentially a dangerous area where, you sort of think, oh, well, that's probably my menopause. There are some symptoms, for instance, bleeding in the urinary tract, that you absolutely have to get checked out. You can't just say that's menopause or that's aging or whatever if I've had a little bit of bleeding. If I wipe myself and there's blood on the toilet paper, that needs to be checked out. So there are things like that you have to be a bit careful about. But the best thing to do is come in and have a word with an expert, either a gynecologist who has an interest, a subspecialty interest in that field, a urogynecologist, or a urologist who specialises in female or functional problems. So these are all sort of experts in different fields that can answer those questions and can help clarify whether these symptoms truly are associated with menopause or not. So we talked about urinary frequency, urgency, but there's other things like urethral mucosal prolapse. So one of the conditions that we see in urology is overactive bladder symptoms, so frequency, urgency, and urge incontinence at times, or just simply having to rush to get to the toilet. The other thing that happens, just like in the vagina, where the tissues get less plump, poorly vascularized, thin, dry, and they sort of get a bit slack. In the urethral space, so the tube that we pee through, the lining there can also get a little bit slack, and it pokes out from the urethra like like the silk lining of a sleeve. It kind of protrudes beyond the cuff. And what you see when you look at people down below is this bright red, cherry red kind of bulge at the urethra. Doctors who aren't familiar with urethral mucosal prolapse or urethral caruncles look at it and go, oh my goodness, you've got a tumour down there or some sort of growth. So they get alarmed and they send you off to a specialist. But these things are super common, and one of the things that is beneficial for it is the use of vaginal oestrogen. When we look at GSM as an entity, we can subdivide it into vaginal symptoms, so things like dryness, discharge, discomfort in intercourse and things like that. We can talk about urinary symptoms, so frequency and urgency, urethral mucosal prolapses, all those sorts of things. We can look at sexual function, so dyspareunia, and we can look at pelvic pain. And pelvic floor dysfunction, which kind of crosses all borders. So pelvic floor dysfunction can be too loose a pelvic floor because the muscles themselves have become less elastic, or they're not contracting the way they should do, or some can be kind of hyperactive. So in other words, they sort of have too much tone from holding on or from gripping or from anticipating pain. You can imagine your pelvic floor gets quite tight. So these are the sorts of subsets of symptoms that we see in GSM. There are some women who the loss of sexual function is not a huge issue for them. And because I'm a urologist, I see couples where guys have had prostate cancer and had something done and maybe had erectile dysfunction following that. And they feel the loss of, their ability to satisfy their partners Whereas their partners are going, I just need a cup of tea and a hug, thanks very much. I'm not particularly interested in going down the path. But for women who are wanting to be sexually active, then yes, it is very, very important. I suspect that, and I do know this as a fact, that there is a bit of a push towards so-called normalising women's sexual function to keep women sexually active. But I do wonder sometimes what the motivation for that is. Anyway, it's a little political, but there you go. Anyway, so let's talk about the treatments. So for vaginal symptoms, the first thing that we always do with all these symptoms is lifestyle changes. And we know that menopausal symptoms are worse in the context of smoking and alcoholism and heavy weight and all those sorts of things. So if we can change some of those lifestyle issues, we can usually help symptoms. It won't go away, but it'll help them. If the issue is mainly intercourse driven, so difficulty with intercourse, pain in intercourse, we talk about the use of lubricants, and remember that some lubricants can actually be irritative of themselves. We talk about vaginal moisturizers. There has been some chat about laser vaginal rejuvenation, but I must caution people that there's not a lot of evidence for safety and efficacy beyond a certain period of time. So that one's, that's a very, what's the word I'm looking for? Controversial, to say the least, okay? The mainstay of treatment with discomfort during intercourse is vaginal estrogens, and it's one of the problems that we face with that is the myth that vaginal estrogens are in some ways unsafe. There's been some excellent studies to show that they are really safe. And even in the situation where there has been breast cancer or uterine cancer, in some circumstances, certain kind of vaginal estrogens can be used. Again, you'd speak to your expert about which ones that would be safe for you. And usually we would consult with the breast surgeons or the other oncologists about which types we'd use. With respect to too tight pelvic floors, because as I said, that can contribute to vaginal discomfort, we usually employ our pelvic floor physios to help with down training if pelvic floor hyperactivity or tightness is a problem. With your urinary symptoms, as I said, the main ones there tend to be things like frequency, urgency, urge incontinence, sometimes urethral mucosal prolapse. Again, vaginal estrogens seem to be quite beneficial. And the reason for that is because we've got estrogen receptors in the sort of bottom of the bladder and the first part of the urethra. So, taking estrogen away from them, it's a bit like taking candy from a baby. They all arc up and your bladder feels a little bit unstable and a bit jittery. Replace it and they all tend to calm down again. Again, pelvic floor physio is really good at strengthening the pelvic floor. So even if your bladder is a bit unstable, you're better at holding on. Okay, they're good at bladder drills or bladder deferment training to get your bladder to back off and take a bigger quantity. And vaginal estrogens, as I said, will help with any urethral mucosal prolapse, those little cherry red caruncles that we were talking about. With respect to pelvic pain, we know that estrogen receptors are on some of the nerve fibers in the pelvis as well. So again, replacing estrogen can help in that sense, but pelvic floor physio is fantastic, great at dealing with pelvic pain. And most of them these days appreciate that pelvic pain is multifactorial. So we kind of work in groups with each other, and that would include things like chronic pain physicians as well. Any vaginal trauma will present, cause problems with prolapse, but other things like putting on weight, chronic coughing, anything with intra-abdominal pressures driving down. Birth trauma, though, would have to be the absolute number one risk factor. But the problem with menopause is that, it really does change the ultrastructure of tissues. So you get less collagen, you get elastin. Where things were stretchy and plump beforehand, they're tight and thin and they don't have any give. Everything hurts. So this is what happens. And prolapse is just another facet of that. If tissues are slacker than they were beforehand, they'll drop. Yeah. Amongst the sort of changes that we see in women, the labial lips on either side of the vagina, they tend to shrink. The tissues get thinner, sort of more glossy, less well lubricated, less plump. They split easily, even with microtrauma like wiping. The skin on the clitoral hood, it sort of shrinks back, and so there's a bit more sensitization there. The opening of the vagina, especially if people aren't regularly sexually active, contracts down. and pulling things apart when you become sexually active again becomes uncomfortable, and pain begets, as I said, tightening of the pelvic floor, and that it's just this pain cycle where it hurts, I'll tighten up, guess what, it hurts again, and off we go again. There's less lubrication, as we mentioned, and just everything feels a little bit on edge, for want of a better reason. Bladder, vagina, sometimes even back passage. I think these days people should be more comforted that there are many more experts out there and there's a lot more interest in this area. The subspecialty groups do talk to each other. All of us sort of attend the same conferences. We're sort of all on the same page with respect to research. And within the subspecialty groups, so gynecologists talk to urologists in the same sort of field, and we cross-pollinate with ideas. So it's a much better field for our patients. And I think most people understand how sensitive this area is and how interested the general public are in this area. So we're upskilling as well as, our patients in that area.